today, we are having the Alexander Glassman lecture. This lecture will be given by Dr. Alan Shatsberg, who is here on Zoom with us today. He is the Kenneth T. Norris Professor of Psychiatry and Behavioral Sciences at Stanford University. I'm going to turn over the Zoom to Dr. Timothy Walsh, who will announce the winners of the Glassman Award, which is given to trainees for their research work done here at NISP. So thank you for joining us, and thank you to Dr. Schatzberg also, and Tim, it's all yours.
Thank you, Christine. Let me see if I can share my screen. And I'll do this. Is that working adequately?
Yeah.
Very good. As you've heard, today's Grand Rounds is the Alexander Glassman Memorial Lecture to be given, as you've heard, by Dr. Schatzberg. But before I introduce him, I'd like to remind folks about Sandy Glassman and give you a little background about this lectureship and the related research award. Sandy was a member of the Columbia faculty for over 40 years and was a towering figure in research on depression and related disorders and their treatment, especially with medication. He was also a mentor to many of us who are now ourselves senior faculty. Sandy passed away in 2011, and in the following year, his family provided a generous endowment to support an annual lecture in his name. I believe that Sandy's kids, Laura Hersher and Steve Glassman, and perhaps his wife, Judy, are tuning in today. I hope so, and welcome. In addition to the lectureship, the family endowed an award to be presented at the lecture to a trainee for their research in their time in the department. This year, we had 7 submissions for the award, which is a landmark number. The committee to review the submissions consisted, as usual, of 3 of Sandy's mentees, Evelyn Attia, Steve Roos, and myself. And since 2 of the submissions came from trainees in the eating disorders group, we enlisted Jeff Miller's help as well. They were all excellent submissions, all were well qualified to receive the award, but in the end, the committee decided that 3 stood out. And they are from Nina Gao, who is only, I use the term lightly, a PGY 3 resident for her paper in the Journal of Clinical Psychiatry on medication use and assaults in the emergency room. Alexandra Muratori for her paper in the International Journal of Eating Disorders on the use of TMS to probe neural circuits in anorexia nervosa, and Milena Van Dyke for her paper in JAMA Psychiatry on the familial transmission of depression. So congratulations to these fine trainees, and we hope for their continued success and for their growth into faculty members in our department. And so now I have the honor of introducing this year's Glassman lecturer, Dr. Alan Shatsberg. Dr. Shatsberg received his MD here in New York at NYU in 1968. He completed his residency training at Mass Mental Health Center and a clinical fellowship in psychiatry at Harvard Med. After serving in the Air Force, this was Vietnam, he joined the staff at McLean Hospital up in Boston and served in several leadership positions there, leading to his becoming clinical director of the Massachusetts Mental Health Center and professor of psychiatry at Harvard, while continuing his research on depression at McLean Hospital. In 1991, Dr. Schatzberg moved to Stanford, where he was named the Kenneth T. Norris Jr. Professor and Chairman of the Department of Psychiatry and Behavioral Sciences, where he served as chair until 2010, and he now directs the Stanford Mood Disorder Center. Dr. Schatzberg has been an active investigator in the biology and psychopharmacology of depressive disorders. He has authored over 700 publications and abstracts, co-edited the Textbook of Psychopharmacology, which is now in its 5th edition, and is co-editor-in-chief of the Journal of Psychiatric Research. He's been president of the American Psychiatric Association, the American College of Neuropsychopharmacology, and the Society for Biological Psychiatry. He's received numerous awards for excellence and leadership from those 3 organizations, as well as the Max Planck Institute, Brain and Behavior Foundation, the Anna Monica Foundation, the University of Pennsylvania, and Weill Cornell. He has 3 honorary doctorates and been elected to the National Academy of Medicine, and he knew Sandy Glassman. So it's a great pleasure for me to introduce Dr. Shatsberg as this year's Glassman Lecture, and I will stop sharing my screen and hand the podium over to Dr. Shatsberg.
Tim, thank you very, very much. And I'm delighted to be here today with all of you guys. And I'm delighted to give the Glassman lecture. As Tim said, I did know Sandy some, and titled this lecture a personal homage to Glassman's influence on research in the treatment of major depression, particularly how he influenced my group, our group at both McLean at Stanford, as well as at Mass Mental Health Center. And I think it's very important to have these kind of lectures to really not only honor those who have come before us, but also to kind of provide a perspective, particularly for younger folks, in terms of the field currently and how it's evolved. And I think these are very, very important. I'm delighted to be here and contribute to the Glassman lecture. So let me see if I can, hopefully we can advance these. This is a disclosure statement. Basically, I'm going to say something about a company I co-founded called Corcept that is focused on glucocorticoid receptor antagonists. We'll tell you more about that. I think that'll be the only thing that will be related to potential commercial enterprise. So I thought I would kind of go through work that we've done that kind of dovetails with Sandy Glassman's contributions, and and where we cross paths, and to give you a sense a bit of our work, but also a sense of how Glassman was had great influence on the field. And it's because of that influence that I'm where I am in part today, from being influenced by many of the folks who have been colleagues before us. And you heard from Tim and about he and Steve Roos having been mentees of Sandy as well. So mentors are really important, and it's a good place to start. Glassman was not a mentor of mine, but he was a friend of my primary mentor, Joe Schilkraut. And they were both born in 1934, as I recall. Joe was a professor of psychiatry at Harvard at the Massachusetts Mental Health Center, and his, I think, first came to fame by authoring a paper that for a long time, and maybe still, was the most cited paper in psychiatry, called the Catecholamine hypothesis of the depressive disorders. And that summary of his and other research, including Julie Axelrod, who was a Nobel laureate at NIMH, set out that alterations in norepinephrine activity were important for in the biology of depression. And that set in motion a tremendous amount of investigation into the biology and treatment of depression. Joe and Sandy had a great deal of respect for each other, and they had certain similarities. Tim and I were chatting before. They were both really dogged investigators. They really would go after a problem that interests them. They had a great ability to sustain it. They also were very, I think, meticulous in looking at data and outcomes from studies. And they were both very creative. The catecholamine hypothesis came out in 1965, was a major step forward for the field at that time, and has been one of the most oft-cited papers in psychiatry. But it also led not only to lots of work on the biology of depression, but lots of work on the first generation antidepressants, or the first generation commonly used antidepressants, which are the tricyclics. And we're going to come to that because that was a place where I think Glassman's first big contributions to the field occurred around blood levels of tricyclic antidepressants. The other mentor that I had at McLean was Jonathan Cole, and Jonathan was a professor of psychiatry at Harvard as well. A very interesting person. I think just to give folks an aside, Jonathan, at age around 34, became the first director of the psychopharmacology branch at the NIMH. That branch included both intramural as well as extramural funding. It's almost a little bit more kind of closer to what Holly Lisenby is doing, now, with kind of doing both intramural as well as extramural work. And as such, he became, at 34, one of the top 3 psychopharmacologists in the world. Nathan Klein was another one. Heinz Lehmann was a second, and certainly Cole was up there. And I was fortunate to work with Jonathan on about 6 editions of our manual of clinical psychopharmacology that we developed. Mentoring was important to them. Mentoring was important to Glassman, as you heard from Tim. And mentoring, I think, has become important to me in terms of our work. And recently we just did our 18th Career Development Institute at Stanford that we do with Dave Kupfer and Erica Forbes out of Pittsburgh. And we have always had Columbia folks. And so for young folks out there, we had Kelly Hagan this year look into the Career Development Institute. We take senior postdocs and junior faculty and into a 4-day academic boot camp. Now, norepinephrine is a good place to start. And I was thinking about Sandy and different times I interacted with Sandy after Steve had asked me if I would do this lecture. And one of the first things that came into my mind was a meeting at Brook Lodge. Brook Lodge was the family estate or home of the Upjohn family. Upjohn was a pharmaceutical company out of Kalamazoo, Michigan. And their principal drug in psychiatry was a drug called Xanax, alprazolam. And there was an interest that we had, our group had, as to whether Xanax had antidepressant properties. And we started to do studies on alprazolam, on Xanax, looking at effects on G-coupled protein using a platelet model with Joe Schildkraut and with John Mooney at Mass Mental Health Center. One of the things we found was that actually alprazolam did have a what we call the heterologous desensitization effect on G-coupled proteins. That was not norepinephrine particularly specific. And it's interesting, that paper came out 30 years ago or whatever, and it's become kind of a very interesting observation. Didn't do anything for years and years, but did come up again because Mark Rasnick, who's recently published in Molecular Psychiatry, a very nice paper looking at lipid rafts effects of various antidepressants, including ketamine and others, and showing a very quick effect on lipids in the platelets of depressives who are treated with particular drugs, and cites that paper because it fits what we wrote. So keep in mind, things may not hit right away, but if they have some substance and they're well done, they often will come back. And that includes artists as well as some of us older psychiatrists, I think. Now, the memory I had of Sandy was a conference that Upjohn organized to talk about the development of antidepressants, because they were interested in whether Xanax could be an antidepressant. And Sandy was giving his talk, and he was talking about, I can't remember what drug it was, and as to whether it was an antidepressant or not, what the side effects were, etc. And he rhetorically asked the audience, he said, what determines whether it's going to be a good drug is, would you give this drug to your mother? And I was in the audience and I shouted out, I guess it depends on what you thought about your mother. So, these things always have a viewpoint. So here's the norepinephrine system. If you look at the right panel B, you can see a presynaptic neuron. You can see a norepinephrine transporter site. This is from a textbook that Charlie and I, as Tim has mentioned, done multiple. We're now in our 6th edition in press. The tricyclics work primarily by blocking the reuptake of norepinephrine. They have some effect on serotonin, but they're marginal compared to the SSRIs, which are the SNRIs. But the tricyclics, like imipramine and desipramine, work by blocking this reuptake site, causing some degree of sequestration of the neurotransmitter norepi into the synaptic cleft, and interacts with a variety of receptors, beta receptors, alpha receptors, etc. Tricyclics block it. And imipramine is desipramine, a potent norepinephrine reuptake blockers. And one of the things that we got into with Shilkraut was, can you start to develop markers that could predict antidepressant response? And Joe was really very, very interested in urinary metabolites of norepinephrine. And why urine? Well, because there was a metabolite, MHPG, 3-methoxy-4-hydroxyphenylglycol, that was particularly excreted in the urine, and which seemed to have a preferential source from brain. 30 to 50% of MHPG in the urine actually was derived from brain. And this was quite a bit different than plasma or norepi, etc. So Joe would spend, and we would do these studies where we collected urine for 3 days. You remember the musical Urinetown that was on Broadway a few years ago? We literally do 3 days of 72 hours of collections to give you a accurate creatinine excretion as well as MHPG. And what you found was that the low values with low norepinephrine excretion, indicating a low norepi turnover, tended to be highly responsive to drugs like nortriptyline, imipramine, desipramine we studied. Proteoline, I'll come back to, was a very potent norepinephrine reuptake blocker, a tetracyclic drug. The elevated MHPG folks tended to do more poorly. They often required something else, lithium, but it was never really clearly shown what those folks would respond to. It was clear that they were relatively refractory to norepinephrine drugs. And so there was a limited data on how to use the high MHPG or the low MHPG finding. Obviously, it was clumsy to collect 72 hours of urine. The other thing is, it was highly affected by drug. It was highly sensitive, so that you needed to have people drug-free. So there are a lot of impracticalities to it, but it was heuristically important for moving the field. And particularly, it was very key because it used particularly desipramine and imipramine, which are quite potent norepinephrine reuptake blockers. And that's how we kind of segue into the first area that I would consider extremely important, and Tim mentioned this, in terms of Glassman's work, and that was the application of serum levels of tricyclic to predicting or correlating with clinical response. And it led to this paper. There was a classic paper that Sandy was the first author, Clinical Implications of Imipramine Plasma Levels for Depressive Illness, published in the Archives in 1977. And there were a number of things in this in this paper that were very, very important for the field. And they're not only important in terms of research, but important clinically, because we adopted using these tricyclic blood levels in clinical practice. Remember, at that point, we only had two classes of antidepressants. We had the monoamine oxidase inhibitors, which were problematic in terms of potential drug foodstuff interactions or drug-drug interactions. Oh, and then the tricyclics. Both of these classes of drugs, were kind of dangerous, right? You take a week's worth of a tricyclic and it can be quite lethal. You take too much of an MAO inhibitor or something else with it, you can have a hypertensive crisis. And so the use of these drugs was relatively limited to very, very special populations, and started with the more severe depressives. So in those days, we didn't treat milder depressives because the risk-benefit ratio wasn't there. And it was only with the advent of the SSRIs, Prozac 1988, that we then started to see that there were milder depressives who met criteria, who could in fact gain benefit from an antidepressant. So the blood levels were very, very important. And Sandy in this paper nicely demonstrated that as you went up in the blood level to 225 nanograms per ml, you saw much higher response rates. Everybody responded pretty much. Whereas at the lower levels, less than 150, you had about a 25 to 30% response. And in between, you had an intermediate level of response. So this then led to aiming for a particular blood level commonly in treating patients with either imipramine or desipramine. There were data also on nortriptyline, which showed that the relationship was different, was basically curvilinear. So it went up to about a blood level of 100 nanograms per ml, and then once you got over 150, you lost response. So it was kind of an inverted U-shaped relationship. Now, we started getting we used tricyclic blood levels for a variety of things. We used them in our studies, we used them clinically. But here's an example of how blood levels we use to start to inform changing recommendations for dosage for existing drugs. This is a drug called meprodaline. Ludiamil was the brand name, and it was developed by Ciba-Geigy, Swiss company. And we did some research on it and showed them low MHPG predicted response to it. This was desipramine, 3-ring structure with a cross-ring bridge between the first and the third ring. So it was a highly kind of stiff kind of molecule. And it was thought to be a very potent norepinephrine uptake blocker. It was released into the marketplace with a recommended starting between 75 and 150 and going up as high as 400 milligrams. So keep in mind, for desipramine and imipramine, 300 was the top. For desipramine, maybe a little lower than imipramine. And it got released. It was started to get used. A problem happened. People started having seizures on the drug. And we started to then collect serum from people who had seizures at McLean Hospital. Eric Desane and Jonathan Cole. Eric was a postdoc with us and practices up in the Boston area. Did the study and published it in the archives in 1986. And we did two things. We went over the history of the seizures that had been reported to Ciba-Geigy and that we had seen as well, to look at the duration of treatment and the dose. And what you could see is that you had a fair number of people who had seizures between 1 to 6 weeks, so 7 to 42 days, who were treated at the 150 to 175 milligrams per day. And then you had the next group at about 200 to 225 milligrams per day that also were between weeks 1 and 6. So that the first big group that you saw were people that were getting seizures early, after a week to 2, and doses of 150 to 225 milligrams per day. There were then a second group of seizures that occurred later, and these individuals had seizures at later than 6 weeks and at doses of 200 milligrams above to about 400 milligrams. So we had a kind of a bimodal distribution. And we were then able to go to Ciba-Geigy and say, look, you ought to change the recommended dosing schedule. let the patient stay between 75 and 150 for the first 2 weeks before you go up, and get the top down to about 250. And they did that. They did that and changed and the drug was on the market probably about 20 years, but it changed the whole thing. I don't know if you could do this today with the variety of bureaucratic kinds of things going on between FDAs and companies or whatever, and academics, but you could do it. You could help the field then much more easily than our rigid structures that we have today. So what we did though in this study is we looked at the blood levels. And you would think, so here are the doses that we had at McLean Hospital. You can see here we had a number of these 400, 250 to 400 milligram individuals. And they had been on their drug for more than 6 weeks, all of these individuals. So these were, except for one, these were all late. They were high dose late. You would think the plasma levels would be enormously high, but they weren't. And what it suggested to us, they're reasonably high, up to 300, but a lot of them were about 120, 190. And at that time, we didn't measure protein plasma levels because they were not thought to be active in terms of the antidepressant effect. But it does suggest that the accumulation of a metabolite was involved at the very high doses. So this led to just a massive a redoing of the drug with a very different dosage recommendation, and really could use the blood levels to kind of start to tease apart these kinds of issues. That work, Glassman's work in tricyclic blood levels was recognized in 2006 and 07 with his receiving the Anna Monica Award. And Tim mentioned that we had received it about 6 years later than Sandy. And I recall, we used to come to New York, my wife and I, because we've got our older daughter and her family and our grandchildren living in Manhattan. And so we would spend for about 8 years, we would spend November on sabbatical working with Jack Barkas and his group at Cornell, because we had Pritzker Foundation supported collaborations. And I remember after a concert running into Sandy and Judy at the second level, third level in, there was a cafe in the Time Warner building. It was after a concert of some sort. And chatting with Sandy, and kind of he was telling me what was happening. He said he was about to go over and receive the Anna Monica Prize, and he did it with great pride, but not with in any egotistical way. It was really a kind of a joy, and a joy in a way of modesty, and it was the kind of, I think, person he was, always inquisitive and always appreciative of people recognizing his work. Also here you see folks from the foundation in the middle. Fritz Henn here is on the left, who was the chair at Heidelberg, I think still then. Isabella Heuser, who's the chair at the Charité in Berlin. It's a German foundation award, and he was duly honored by receiving it in 06, 07. The other thing that Sandy, where Sandy had a great deal of influence on me personally and my group, separate from Joe Schildkraut, was in this idea of a psychotic subtype of major depression, and he certainly was very interested, and I think it was the first place that or one of the places where he kind of interacted with Steve Roos and published some very seminal papers. But it came out of the tricyclic blood level study. And this is from that same paper I showed you before in the archives in 1977. And what Glassman had shown up on the top is that responders to the drug had, these were depressive, all depressives, had a much higher response if they, over 70% if they had a blood level of 180 nanograms per ml, and those who had a much lower didn't. notice the very simple kinds of statistics used here, chi-square. We hardly see the Fisher exact and the chi-square anymore. Everything has got to be AI and machine learning and this and that. And picking out needles and haystacks. This kind of gives you a sense, that either the finding is there and it's clear, or you've got to wonder about the finding. And it's something that I think it gets blurred in current research. We tend to use regression models and mixed effect models and this and that, but the findings should be pretty robust. Now, you want to have larger ends, I understand that, et cetera, but it is still the finding. Now, what came out of this, though, was that he had a series of individuals who were delusionally depressed, who were psychotic. And he saw in those individuals, generally they were non-responders to the tricyclic, imipramine in this case, and blood level did not matter. Whereas if you deleted those delusionals, you even had a more powerful effect. 19 out of 20 on the lower right here, C, responded versus 6 out of 22 for the non-diluted with the lower plasma level. So Glassman then said, there's something different about this group, and went on to do a paper in 1981 on delusional depression in the archives, and he did it with Stephen Roos, who is a friend and was a mentee of Glassman, and like Steve, like Tim, Steve is a professor at Columbia, and still continuing to do research in another area we'll come to in geriatrics. So he started to raise this notion that delusional depression was different than non-delusional depression. And there were a number of observations he made on psychotic depression. One was that there was a low placebo response rate in these individuals. We're going to come back to that as to whether that's the case. The studies that, as I recall, that Glassman did on the blood levels used a placebo run-in, where not a placebo randomly, an RCT comparing imipramine to placebo, but they used a placebo run-in, and they eliminated the placebo responders. And the psychotic depressors in that study showed a very low placebo response, but it was not a double-blind comparison. He showed this lack of relationship of imipramine response to blood levels, and he reported that there's greater psychomotoric retardation in the than seen in non-psychotics. And in a separate paper, done actually on looking at successful, quotes, suicides at PI, that the individuals who suicided tended to have delusions. So that started us in part, and how we came back to it. Those intriguing observations really started myself and Tony Rothschild at McLean and continued after I moved to Stanford, of about 35 years of research into psychotic major depression. I want to spend a bit of time kind of going over some of the findings and how they kind of replicate or don't replicate, mostly replicate Sandy's observations, and tell you where we are on the potential treatment. So what is psychotic depression? It's mood congruent, generally mood congruent, delusions of guilt. I've done something bad, often, but delusional, where they haven't. Deserve punishment. I've done this thing that's bad and I deserve to be punished. Nihilism, these folks will voice being impoverished when they're not. They will say that they have somatic kinds of illnesses. I have cancer, and where they don't. And they can hallucinate, but only a third of them hallucinate. It's typically auditory, and it's typically transient. So we've done multiple studies over the years on different aspects. And one of the things we did was to try to determine what the actual current prevalence was of psychotic depression in the general population. And this is a study that Mauricio Hyen and I did on his data set of 19,000 subjects studied in 5 European countries using a method of gathering data on medical illness as well as psychiatric illness called a sleep eval system, and sleep, because he's primarily a psychiatrist doing sleep research. And we estimated in this 5 European countries a current prevalence of non-delusional depression of about 2.0%, and a current prevalence of psychotic major depression of 0.4%. This was about 18.5% of major depression subjects in the community were deluded. This was then about 2 years later replicated by a Finnish group who I think went into it, I've been told, being somewhat skeptical as to the finding. And Finland has these phenomenal data sets. And they reported in the archives a prevalence rate of 0.3%. So that seems to be what the prevalence is. Pretty common, it's not uncommon. The previous study that Myrna did with Johnson in the archives based on the ECA study used a looked at lifetime psychosis in a cohort of current major depressives. And there they got a higher number, 0.8%. But the current prevalence of delusional depression is about 0.4%. To give you a sense of, a lot of famous people have died killing themselves because of their delusions. This is from the suicide note of Virginia Woolf. Dearest, I feel certain that I am going mad again. I feel we can't go through another of those terrible times, and I shan't recover this time. I begin to hear voices, and I can't concentrate. So I am doing what seems the best thing to do. And there have been other clearly delusional depressives who killed themselves. Forrestal, who was the Secretary of Defense at the time of the founding of the Pentagon, etc. Now, most of our biological work and clinical work in typing the delusional depressive subjects has revolved around excessive HPA axis activity. Glucocorticoids, the HPA axis, are released by the adrenal. The stimulation of the pituitary occurs by release of CRH or CRF in the hypothalamus, also found in the hippocampus, and it stimulates the pituitary to release ACTH. ACTH then stimulates the adrenal to release glucocorticoids, and you get feedback inhibition at the level of the pituitary, feedback inhibition at the level of the hypothalamus. You can challenge this system by giving a synthetic steroid, and this is where Barney Carroll's contribution came on the dexamethasone suppression test. You give a milligram of dex at 11 o'clock, you look at the cortisol the next morning or at 4 o'clock. He emphasized 4 o'clock, and patients should have values under 5. Over 5, that means that they're not suppressing, and it suggests some disorder of the HPA axis. One of the things I do want to point out, and we'll come back to it later, glucocorticoids, though, act throughout the brain. One, because there are glucocorticoid receptors, and they are found not at they're not found at synapses. They're nuclear receptors that bind to DNA and cause transcription changes. So about 20 to 30% of genes in the brain are regulated by glucocorticoids. So it has an effect on dopamine, on norepinephrine, et cetera, et cetera. But glucocorticoids affect other systems besides what we call the hypothalamic pituitary adrenal axis. In the amygdala, glucocorticoids, in fact, increase CRH. They don't inhibit CRH as a negative feedback. There is a positive loop there. So it may very well be, and we think, that the effect of glucocorticoids in the amygdala is very different than the effect of glucocorticoids on the hypothalamus and the pituitary. So we got into this because we were interested in dexamethasone suppression tests, and we decided to look at DST in a group of controls, as well as in patients hospitalized at McLean Hospital with Tony Rothschild. We published this in 1983. So this was a couple of years after the Glassman-Roos paper. And what we found was that there were patients with major depression who were above 5, so they show non-suppression. Controls, only 1 out of 31 was non-suppressive. But when we looked at this, the signal tended to, we looked at what was driving these patients, what was different about them, was that everyone who with a value over 15 was psychotic, and about 80% of those above 10 were psychotic. So the individuals with psychosis and depression were those who were markedly hypercortisolemic and showed marked resistance to suppression by the synthetic steroid. And it wasn't just melancholia, as Barney had argued, or endogenous depression. It was really the co-occurrence of psychosis, which really fit what Glassman was saying, that this disorder is different, has a different biology. So one of the things that is very pleasing, and this is something out there for the younger folks, it's very important to be replicated. You know, you're out there at times, you're taking a chance, and there have been 3 meta-analyses, each done in a different decade. 1986, Arana and Baldessarini reported that the single biggest predictor of DST non-response in depression was psychosis, replicated by Craig Nelson then at Yale and Davis at Yale, looking at the DST and a meta-analysis, and then Stetler and Miller, 2 German investigators, looking at multiple measures of HPA activity, including urinary cortisols and plasma awakening cortisol, etc., and salivary, showing that the psychosis is, in fact, the driver in depression for hypercortisolemia. So it is very nice to be replicated. You may be out there hanging in the breeze for a long time, but it is nice to be replicated. And no matter when. And then recently I was talking to Christine, and we've gotten very interested in the question of whether ketamine's antidepressant effects are mediated through some mu-opioid receptor, either agonism or release of endogenous opioids, and which we reported in the American Journal in a study in patients that naltrexone blocked the antidepressant effect. And now there are 5 published replications that naltrexone, naloxone blocks the antidepressant effects in rodents, administered ketamine. So this is just to give you an example, the Nelson John Davis report, 61% in their meta-analysis of 1,000 patients of non-suppressives in PMD and psychotics, and 41% in non-psychotics. So we then started to do a variety of further studies. One of the things we were very interested in is to characterize the curve, the diurnal rhythm of cortisol in psychotic depressives. And what we showed in a study, the first studies we did, was 72 hours of hourly collections of cortisol in a GCRC. And we showed that there was elevated cortisol activity, but the curve really was mainly in the evening from 6 p.m. to 1 a.m. and a bit in the morning. And you could then, in fact, focus that down. And we then did that. And this is about 130 subjects in one of the NIMH grants we had. And we showed that the psychotic group had significantly elevated cortisol starting at 6 p.m. in the evening. We put the IV line in at 4, and you can see it continues out to about 1 a.m. And then the curves come together going into the morning. This kind of approach, by the way, of looking at cortisol over in the evening, certainly was not, we didn't start this or whatever. And in fact, one of the great contributors to this on a historical basis was an earlier chair of psychiatry at Columbia, Ed Sacker, starting his work at that point at Einstein and then coming over to Columbia. And Ed was one of the great early cortisol and stress researchers in depression. So you can see here you have elevated activity. The other thing is, if you look at the healthy controls, you can see here at 6 p.m. the value is about 5.5. And when you get down to about 11 to 12, your values are around 3. And so you can see there is a steep slope going down in the evening. And that's because mineralocorticoid receptors that bind to cort are suppressives of the HPA axis. That is a normal diurnal rhythm. The essential function of the HPA axis depends on forming a nadir. The nadir is absolutely the key. And the difference between delusional and non-delusional patients and controls is that they have an incapacity to, in fact, drive down their cortisol in the expected diurnal rhythm of cortisol. So this is that study. We then also started to be interested in neurocognitive measures, neuropsychological deficits. You remember Sandy and Ruth said these folks have marked psychomotoric retardation. They're slowed down or whatever and have concentration. And so with our group and others have also, there's also been multiple replications. You can show what the deficits are. They tend to be deficits in attention, deficits in executive function, and response inhibition. And they have verbal memory deficits, story learning, declarative memory, etc. A lot of the verbal declarative memory deficits, and these are mostly from our group, but others as well, really are dependent on the fact that the patients have a difficulty in attention and in coding. And you can demonstrate that by using a verbal declarative memory or story learning or whatever. The patients, when you ask them the story immediately, have difficulty. When you ask them 20 minutes later, they're actually of what they could get in the immediate recall is preserved. So they can actually, if they have trouble encoding, once they can encode, they can retrieve. And these kind of studies give you a sense of trying to kind of split out what the cognitive kind of problem is. So the treatment response of psychotic depression is quite interesting. We heard from Glassman that they, in his paper, that those patients did not respond well to tricyclics. He thought historically there was a low placebo response. I'm going to show you data to say that it's probably not true anymore, partly because of time, placebo responses have gone up, and partly because when you do an RCT with a random assignment of placebo, you do see more placebo response. The treatments that work are amoxapine, which is a derivative of loxapine, an atypical antipsychotic, antidepressants plus antipsychotics. Those tend to be the best studied and the most commonly used, olanzapine plus SSRIs or ECT. And there was a thought that they might respond to SSRIs alone in high dose. That came out of Italy. There are open label studies, but no real blinded studies. And atypical antipsychotics, there was a thought that olanzapine, which is effective by itself in mood disorders, could be a good treatment for psychotic depression, did not separate from placebo in 2 studies that Lilly conducted, and we were part of setting up those studies. So there are no real FDA-approved treatments. ECT, probably the most effective treatment. I don't know if Harold's on the call, but Harold and Prudek have nicely shown in their epidemiological study, quasi-epidemiological study, that they had the highest response in delusional depressives in these community-based ECT programs, but the highest rates of relapse within a month. So most effective, but most difficult to maintain the response. Now, novel treatments and unique mechanisms of action is something I'm going to talk to you about now. But I do want to point out that Glassman, and we're really talking about 2 pieces of work for Sandy. One is very nice work on tricyclic blood levels. The next kind of beginning to identify and map out delusional depression as a disorder. But he had 2 major other areas that he was a great contributor to. One is this notion of the comorbid heart disease and depression. and started with questions of what drugs are safer and not safe in depressed cardiac patients, with very classic papers on nortriptyline and SSRIs that he and Steve Roos did. But also kind of common kinds of biology then led to his SAD heart study showing us, or enriched studies where sertraline was shown to have some benefit in individuals in heart failure and depression. But the other area where it was a big contributor is the whole question of comorbid smoking with major depression, and the question of whether you can use nicotinic kinds of drugs for treatment. And so these were 4 areas of tremendous contribution to the field that he really needs to be remembered for. And the smoking comes up just in the last week alone. I don't know if you saw JAMA, a paper out of NIDA, Will Compton, showing that smoking use has decreased from 30% to 20% amongst depressives, and also that you could, in fact, help get depressives stop smoking in terms of treatment. That paper, just a big paper, came out in JAMA, and it just reminded me of the contribution of Sandy to that whole area of research as well. So this is a different way of getting at treatment, and this is of, can you in fact block the excessive activity of the HPA axis and help people's delusions and depression? And so there are 2 receptors I mentioned to you. One is the mineralocorticoid receptor. This is a high affinity receptor for cortisol. And so this binds strongly. The agonist is aldosterone. Spironolactone is the antagonist. It's found in the limbic structures, and it drives down the HPA axis to the nadir. And then there are the glucocorticoid receptors. These are low affinity receptors, only activated during high periods of stress or stressful illnesses, psychotic depression, etc. The agonist is dexamethasone, so that's how you test the HPA axis. And these are found throughout the brain. And one of the things we did with Paresh Patel and David Lyons is we mapped the distribution of the receptors in primate brain. This is looking at the mineralocorticoid receptor. You can see here in the coronal sections, when we get into the hippocampus, there are quite dark binding to the antibody, and you can see there is a lot of mineralocorticoid receptors. But look at the cortex. The cortex has tremendous amounts of binding to the glucocorticoid receptor, including in the hippocampus. More MR, but also in the hippocampus. And the reason I point this out, there was a paper by Mar Sanchez and Tom Insel out of the Yerkes at Emory that used a human antibody against a rhesus monkey and failed to show binding of glucocorticoids in the rhesus monkey hippocampus. We did this using a raised squirrel monkey antibody, and you can see there is. So mifepristone, you've all heard of mifepristone, and it's come up probably again just in the last 48 hours with this whole Supreme Court business and abortion. Mifepristone is RU46. It was formulated by Roussel Uclef in 1981. It's approved for abortion in Europe and Asia in 88, approved in the US in 2000. And it's a progesterone receptor antagonist, but it's also a glucocorticoid receptor antagonist. Cortisol and progesterone, high homology. The receptors, high homology. And any drug that's a steroid moiety that binds to progesterone will bind to the glucocorticoid receptor because the size of the differential of the glucocorticoid receptor and the progesterone. So this drug is, in fact, not only used for abortion, it is approved, and this company that we co-founded 20 years ago markets it for Cushing's disease. because in Cushing's disease, many patients you can't find the tumor of the pituitary, and so they need to block their cortisol, and the cortisol, and it's life-saving because the mortality, 5-year mortality in Cushing's disease is 50%. So we in fact tested, Lambert's showed that Cushing's patients who were terminal, who became psychotic, a frequent problem as psychosis and depression, rapidly in fact showed a reversal of their psychosis if you gave them mifepristone. So we hypothesized that you could do that, and we did a study. We started to do studies where we gave mifepristone against placebo, and first we did a 4-day study on and off crossover study. We showed that 4 to 5 people responded very quickly. Then we did this study where we looked at response at 1 week. We treated for a week, and we looked at response at 1 month. And you can see here, you had just treating for a week, half of the individuals with mifepristone responded compared to about 15% with placebo. This was NIMH funded. This drug this would be an off-label use. It's not approved for it. Keep that in mind. But we then but one of the things that happens if you give individuals, psychotically depressed patients, mifepristone, what happens is you have this elevated cort in the individuals at 6 p.m. You can see the value of 13 is very high, and here's the baseline here is pre-mifepristone. You can see the value is about 9. You can see there is some nadir, but not dramatic. And when you give mifepristone, you develop this hyper extension of the curve. Cortisol goes up, but then it comes way down to the nadir, and then it releases. And so what mifepristone does is it normalizes the HPA, hypernormalizes the HPA function. Now, going back to Glassman, what we started to notice when we went into phase 3 to larger studies is that, in fact, you had to push the dose to get enough response. The original studies we did were 600 milligrams, which is the abortifacient dose. And this is now 440 patients treated at 3, 6, and 1,200 milligrams. And what you find is that we didn't separate from placebo. We had numerical superiority, 44%. So you only treat for a week, and you're getting 44% of them better going out to 8 weeks. Only treat for a week. And so you get this carryover effect. But we also had a 34% response for placebo. So remember, Sandy argued you don't get a placebo response. That was a single blind run-in. When you do a placebo-controlled trial in the patients in the hospital, as in schizophrenia, as in other things, we are getting placebo response. And it's the bane of many of us research. Now, if you do the blood level, the therapeutic blood level, very much like Sandy did with the imipramine, you see a very dramatic response. 52% respond in a week, stay well to 8 weeks compared to 34% on placebo. And this last couple slides gives you the roll-up of 5 placebo-controlled trials at the different doses, 1,400 milligrams, 1,460 subjects. This is what you see when you look at the blood level cut at 1,637. You see a highly significant effect on the forest plot of individuals with the higher blood level compared to the lower blood level. And this is what you see at the clinical response. You see a 30% on the 5 studies, 1,400 subjects for placebo, 30.6% for the low blood level folks. But the folks who achieve the higher blood level show a good separation, 42%. So blood levels, this was published in 2018. Glassman starts in 77. 2018, we're still using blood levels to understand treatment response. And since we know if you give dexamethasone, the HPA axis is supposed to go down. If you give mifepristone, as I pointed out, the values of cortisol go up. You do see a nadir, but they go up. So here are the cortisol and ACTH differences at noon And what you find is that on placebo, you get after 7 days very little change in the psychotic depressives. In the low plasma level folks, you get a rise in cort of about 6-fold, and you get about an 8-fold rise if you're above the therapeutic level. And you can do this with ACTH. You get a much bigger response rate biologically readout on the HPA axis. Now, what we then did was a mediator analysis, which is the bigger predictor. Is it the blood level, or is it the change in cortisol and ACTH? Remember, you give mifepristone, you're blocking the receptor. It doesn't lower cortisol. The cortisols go up, but the glucocorticoid receptor is blocked. And what we found was, indeed, it's not the readout on the cord of the ACTH, it's the blood level that is the much more commands response, which suggests to me that in fact it's probably not the effect just on the pituitary and the hypothalamus. It's probably also particularly important to block the effect in the amygdala, where there are a lot of receptors and where, in fact, the anxiogenic kinds of properties are probably located. So the company is no longer developing this. It really is mainly a cancer and endocrine company, and it may come back to it. But it just gives you a model of how you can kind of pursue an area of research, and one that really was highly affected by the papers that Sandy Glassman wrote. By the way, the NNT, if you look at the high plasma level, is very good. It's about 7. Treating for a week, looking at response at 1 week and 8 weeks, pretty dramatic. And so psychotic depression is severe. It has a cognitive effect, as Glassman argued. It probably has more placebo response, unfortunately, than we thought originally in 77. Mifepristone seems to be effective. But it has limitations. And the big limitation it has is the kinetics are not linear. It flattens out. So once you get to 1200, you go to 1800, your levels do not go up. And so you would need a different glucocorticoid antagonist to, in fact, develop it. Joe Balinoff was an original postdoc of mine, who actually is the CEO of Corcept, has worked on this for years. Thad Block, Chuck DiBattista, a number of other folks, and funded by the NIMH and Norris and Pritzker's, et cetera. So that is where we are, and I'm delighted to take any questions. I don't know if I can answer them, but I'll try, Christine. But I do think, again, it's very important to kind of put a perspective on somebody's work, particularly somebody like Sandy, and how it affects other people. And frankly, before I got this call, I hadn't really been thinking about Sandy Glassman's effect on my own career. But when I look back, it was certainly had primacy. So thank you very, very much.